Good afternoon, everybody. My name is Flensted Lassen. My topic is why proximal optimization technique is so important in the left main. But before we embark on that discussion, we need to dive a bit more into the biology and the laws of nature in coronary arteries. The coronary arteries divide in a fractal manner, and what does that mean? Well, we can see from another part of the nature, a riverbed from pictures taken from above. In the upper panel, we can see a river from 2 kilometers height in the left picture. And this is actually have a configuration that is very, very similar to the configuration of coronary epicardial arteries. If we go down to 500 meters altitude, and still it's Google Earth, it is real life somewhere on the planet, we can see the minor part of that river, which is actually comparable to the resistant vessel in the coronary arteries. And if we go even further low to 100 meters, as in the right panel, we'll see the small brooks that feeds the river, which is actually pretty close to the capillaries in the coronary arteries. And in the lower panel, the green picture, we can see a Malaysian river depicting the appearance of an epicardial coronary artery. And all these pictures show how a division is, if seen by a fractal manner. But it's not enough to understand the biology. Another thing was heavily discussed by C.D. Murray in 1926, and it was actually that the diameter of the branching in dividing coronary arteries correlates to the physical principle of minimal workloads. It also comes back to the angle of the branching arteries and the oxygen exchange in capillaries. And I really encourage you to look into this literature from Physiology 1926 to understand the biological background behind. But which are the implications of this? Well, from Murray's law and from some of our other colleagues, Girard Finet and our friends Hu and Kassab, the relation between the diameter in the distal part of a bifurcation and the proximal part is depicted in this picture. And this has implication because when we start stenting an area, we have to realize that a stent is tubular, but actually there is a huge discrepancy in the diameters from the proximal part of the main vessel to the distal part of the main vessel, which means that we need to manufacture the stent to the biology. Otherwise, we may hamper the biology. One thing that really is important is to realize that if we overdilate the distal part, we'll push the carina towards the side branch and then maybe close it. If we're going back to the topic, the left main, there are differences from the left main and all the other bifurcations in the coronary tree. One of the first differences is the oval shape of the ostium and the angulation, which means it's difficult to cover the ostium totally by a metallic stent. There are curved diversions and there are differences in the angle between the two side branches, but even more importantly is that the side branch is actually the circumflex, which need to be protected because it could have lethal complications for the patient if the side branch is loosed. And yet another thing is back to the fractal division and the dimension changes from the proximal part of the main vessel to the LAD. There is a huge step down of this tapering vessel from left main to LAD, which means that if we implant the stent with respect to the left main, then it would be heavily overdilated in the proximal part of LAD, and there will be a high risk of pressing the carina towards the side branch and close to the side branch in that respect. So now we are coming back to why do the proximal optimizations, and there are different reasons for doing that. But first of all, what are the steps and what can we do? So the first step is actually to implant the stent across the side branch with respect to the distal diameter. This is of course very important because that covers and protect the distal vessel and make a good stent deposition in that area. But we need to accept a floating stent in the proximal area which need to be corrected for. This is done by taking a balloon with a larger diameter and place it with respect to the carina, as it can be seen here, and dilate it. Then we actually changed a tubular stent to be a tapered device, and we opened also the stent struts towards the side branch and preserve the side branch opening. If we pot too deep with the balloon, we'll actually push the side branch carina towards the orificium. We will overstretch the distal part, and we will maybe lose to cover the proximal part, introducing another problematic thing, which we call the bottleneck. If we, on the other hand, pot too high, we will not open side branches enough, stent struts enough to the side branches, which is another problem. So again, we need to manufacture a tubular stent to the biology, which needs to have a larger diameter in the top and a fitting diameter in the distal part, and at the same time opens towards the side branch. This is the proximal optimization technique. The proximal optimization technique can be done crossing over the side branch, but it can also be done reversely, as seen here, which means that we can start a left main procedure by provisional stenting and make the procedure built upon stepwise until we finalize. Maybe with 2 stents, but we may be able to stop with only 1 stent. So we can both protect the side branch up front and the main branch. It introduces different risk for the takeoff vessels, but this is not the topic for this talk. Why do we perform the pot? Well, it's reasonable to understand from what I've already said, but here we have from Visible Heart Lab in Minneapolis a direct angioscopy of a stent implanted with respect to what we were discussing, the distal diameter and the floating part in the proximal. And look what happens when we try to rewire. There, we just went behind the stent struts. And you can imagine what happens when we bring in balloons or other devices. We will actually deteriorate the proximal stent and maybe cross it. So it's extremely important not to lose the wire and be actually sure that you are not below stent struts if you lose the wire. So it's very important to do the pot after the first balloon dilatation to be sure that we actually change the geometry like this. Nicely wired within the stent and dilated, as you can see on the angio on the right and in the angioscopy on the left, making a very good stent position and avoiding the bottleneck. You may appreciate that there might be some floating struts in the proximal area. It will be corrected for in a bit. Next step would be kissing balloon dilatation, which has the purpose of open stent struts towards the carina and place the float divider in the middle. And again, from this angioscopic view, you can see the passing of the balloons, the passing of the wires in the distal cell strut, making a better coverage of the proximal roof of the side branch, and a nice result in the end. Okay, so after having implanted the stent and manufactured it the way we want it, it's possible to move further on if we need more stents, either with a T-tap or a culotte, if needed. But there are other possibilities, as we can see in this quite busy slides. The DK cross technique is a 2-stent technique up front, which actually don't leave the possibility to have only 1 stent. But also in these situations, it's important to have a proximal optimization in the left main, for the reasons that the stent is actually going from the ostium and the guiding catheter can cross the stent a bit. We need to take care of the carina area, open up to the side branches and have taken care of everything. And then after the procedure is basically done, we finalize with a proximal optimization to correct for the oval shape and to correct for the crossed area. So having said that, we have the reason for why POT is so important in the left main. Thank you very much for your attention.